Hello, and welcome to Opt to Thrive, episode number 9. Let's talk about sex.
Welcome to Opt to Thrive, your go-to podcast for women's wellness in midlife, designed to educate, support, and inspire you to live your very best life. And now your host, Dr. Karina Sims.
I hope you'll forgive my voice today. I have a little bit of a cold, nothing serious, but it's going to sound a little bit nasally. I do apologize. What an amazing day it is today. I kind of think that we've gone through the rough bit of the winter days. I think the nights are a bit cold, and that's okay. I can handle a few cold nights. As long as the days are amazing like this, blue sky, it's a bit warm out there, it's lovely. And the garden's coming along beautifully. Still got a bit of work to do, but going in the right direction. So we're going to get started because we've got a bit to talk about today. Like I said, we're going to talk about sex, in particular, the lack of it for a lot of us during this midlife transition period. And what the hell is going on with our bodies? Now, there are some women that report that they enjoy sex more at this stage because they no longer have to worry about what other people think. And they feel a sense of freedom as they age. And then, of course, that's that whole, if you're postmenopausal, don't have to worry about contraception. But others, in fact, somewhere around 40% of us might find that they no longer feel sexual desire and they no longer want to have sex. Now, this can go a few ways. So there are those who really aren't fussed. They don't miss it, wouldn't be bothered if they never had it again, and off they go, merrily on their way, really not interested in even talking anymore about it. Great, good for you, if that's you. But then there are those of you who would like to do something about it. Maybe they feel that same way, but the partner isn't quite there yet. That can cause a lot of trouble in the relationship. And maybe the woman would decide that even though she could quite happily live without it, she still wants to share intimacy with her partner in this way. And so she wants to do something about it. And then we have the women who do miss their libido. They miss having that desire and they really do want to do something about it for themselves. And so for both of these groups, it can be really distressing, losing your libido. Now, what we know is that many women won't even bring this up with their doctor, sexual desire or problems with sexual function. And if they do, they often walk away without an adequate management plan. And there are at least a couple reasons for this. So many healthcare professionals don't feel confident in managing female sexual dysfunction. In one survey of around 2,000 physicians in America, they found that approximately 60% of participants rated their knowledge of and their comfort level in diagnosing or managing female sexual dysfunction as poor or fair. And then those doctors that felt confident in assessing and managing didn't feel that they had enough time to do a proper assessment of the problem. Now, I've been fortunate enough that a lot of women have felt comfortable coming to me and talking about the decline in their libido, but in the past, unfortunately, I often didn't feel I had adequate treatment strategies to offer. I certainly feel a lot more confident now, which is one of the things that this whole midlife transition has done for me, which I'm grateful for. But I once reached out to a gynecologist for advice about how she manages these patients because I was looking for solutions and help in managing these patients. And she said to me, "Look, Karina, it's like this. Let's say it's Friday. It's been a long week. You're tired. You really just want to go home and lay on the couch and veg out. But you have committed to going to some kind of an event or party. You don't really want to go, but you made a commitment. So you put your makeup on, you get your heels on, you get yourself out the door and to the party. And once you're there, you're happy you came." And so, yeah, it was pretty much like that. Just suck it up and get back in the ball game, which I can't say was overly helpful. Now, fortunately, things have changed, and I found a lot better information and treatment strategies to offer my patients, and so we're going to go through a lot of that today. I think sexual health is really important. And so I really want to explore it thoroughly, and hopefully you will walk away today with some strategies to discuss with your doctor, or other strategies that you might be able to do on your own, and see if those things help for you in improving your sex life if that's something that you want to do. Now, low libido is defined by at least the Australasian Menopause Society, which is our governing body for all things menopause in Australia. They define it as the diminished desire for sex. Low libido is the most common sexual concern reported by women, and I can say I do get this complaint a fair bit. Now, clinically, there are a couple of terms that we use when we're talking about low libido. And up until recently, it would have been labeled something called hyposexual desire disorder, so HSDD. So the criteria for HSDD were that you had to have a persistent or recurrent absence of sexual desire, and this had to cause significant distress or interpersonal difficulty, had to have been for at least 6 months, and the lack of sexual desire could not be better explained by another mental disorder, medical condition, or as a result of significant relationship distress or other stressors. And it also shouldn't be due to the effects of a substance, so a medication or drug use. Now, recently, HSDD has been merged with female sexual arousal disorders and renamed Female Sexual Interest Arousal Disorder, FSIAD for short. So it's still pretty much based on sexual desire, but it also takes into account that for a woman, sexual desire and arousal are complex and they're often interlinked. So if we look at both interest and arousal in making diagnoses, our treatment strategies can be more targeted, and we can address both the physiological and the psychological components, which can make our management more effective. So this diagnosis comes from the Diagnostic and Statistical Manual of Mental Disorders, the DSM, and the newest one, which is the DSM-5, which is the most current. So this is a comprehensive classification system that health professionals use. It provides us standardized criteria for diagnosing disorders, and so that we can all kind of be on the same page across clinical research and educational settings. To make this diagnosis, you have to have 3 of the following 6 symptoms. Number 1, an absent or reduced interest in sexual activity. Number 2, an absent or reduced sexual or erotic thoughts or fantasies. Number 3, absent or reduced initiation of sexual activity and typically unreceptive to a partner's attempts to initiate sex. Number 4, absent or reduced sexual excitement or pleasure during sexual activity in all or almost all, between 75 to 100% of sexual encounters. Number 5, absent or reduced sexual interest or arousal in response to any internal or external sexual or erotic stimuli or cues. And number 6, absent or reduced genital or non-genital sensations during sexual activity in almost all or all, between 75 to 100% of sexual encounters. Now, 3 of the 6 symptoms must be present for at least 6 months, and they need to be causing clinically significant distress. So if a woman is not bothered by it, we do not call it a disorder. She has to be distressed. Now, there are physical factors that can contribute to female sexual dysfunction, and I'll just kind of quickly go through the list, and then today we're going to focus on the most common ones. We'll start with genital factors. So if someone has a congenital malformation, if they've got an STI or an STD, if you're one of our North American friends, so a sexually transmitted infection, if they've had genital mutilation, if they've got something called the Genitourinary Syndrome of Menopause. We're going to dive into that one pretty good today. If they've got some skin conditions around the vulva, which is that outside bit, some people call it their lips. So you've got the vagina, and then the vestibule is the part between the vagina and the vulva. The vulva is that outside bit, the part that would touch your underwear or your pants, that bit of skin. If they've had obstetric trauma, that could cause problems. if they've had post-surgical narrowing of the opening of the vagina, if they've had radiation in the area and they might have some scarring or called fibrosis, if they've had recurrent tearing of the opening of the vagina, or any kind of vaginal infections. Other physical factors, like if they've had their ovaries removed before menopause, when a woman is breastfeeding, if she has a physical disability, if she's tired, and there's lots of reasons that could be, an iron deficiency or something wrong with her thyroid, if she's got hyperprolactinemia, high blood pressure, nerve damage from diabetes, multiple sclerosis, peripheral neuropathy, or some kind of a spinal cord problem, if she has ovarian insufficiency, if she's got a substance use disorder, as I said, thyroid disorders, or some kind of a hypoadrenal or hypopituitary state, or if she's got urinary incontinence, certainly could contribute. And then there are some medications and other things that can interfere with a woman's libido or sexual function. So antipsychotic medication, steroids, alcohol, certain antidepressants, particularly SSRIs, which is one of the most common antidepressants that we use in clinical practice, antihistamines, anti-seizure drugs, beta blockers, and other blood pressure medications may cause some trouble, and then opioids. Apart from those things, one of the first things that we should talk about when a patient comes to us with a problem with their libido is the relationship, because what we know is that study after study has shown that sexual satisfaction is most closely correlated with satisfaction with the relationship. So really important that you get that dialed in. If there are some relationship issues, then it's probably worth getting some counseling and exploring that and seeing if you can fix that problem, which would then hopefully really help with the libido issue. And then there are things that are related to what's happening in your body during this menopause transition in particular. So things like changes in body weight. So gaining weight can affect your self-esteem and maybe you're not comfortable being intimate because of that. In this case, implementing a regular exercise program could really do wonders for this. So I did do an episode on exercise, so an episode for the #1 health hack ever. So that might be worth checking out. And then there could be emotional changes. So you might feel stressed. At midlife, often there are a lot of things going on in our lives. Often we have aging parents. We've got work stress, home stress, a lot of stress. And so it might be worth looking at if that's a problem and managing stress. I did do an episode on stress. It might be worth checking that out. If you're irritable or you're upset, if you can't stand listening to him breathe sometimes, it makes sense that you probably aren't really interested in being intimate. So looking at the mood can be helpful. Again, here my go-to has always been exercise. It can be very, very helpful in managing mood, and then all those natural things, getting plenty of sunlight, eating well, avoiding alcohol, sorry girls, and that kind of thing, managing your mind. Again, I did another episode on that. Changing your thoughts can change your life, so you might want to check that one out. But as always, if you're concerned about your mood, if you're having thoughts of self-harm or of harming anyone else, or you're more down than up most of the time, then it's worth having a chat with your GP. Reduced libido can happen when we have this decline in our hormone levels around menopause, in particular estrogen levels. We're going to talk about hormones a bit more later on. And then if you've got the sleep disturbance like I had, which was pretty bad, so even if you don't have troublesome night sweats that affect your sleep, but you're still waking up through the night with disturbed sleep, then that could affect your energy levels and maybe you just don't have the energy. And again, I did do an episode on sleep, so you might want to check that one out, see if you can clean up your sleep hygiene a bit and see if that could help. And then just keep in mind for most of those things that I just mentioned, hormone replacement treatment or menopause hormone treatment is something you might want to discuss with your doctor. Then there's all the changes that are going on around the VJJ. Vaginal dryness is very common We lose our ability to lubricate around this period of time in our lives, and it can make penetrative sex pretty uncomfortable. Some women describe it as like having razor blades in there. And so if it's painful, of course, that can put anyone off of sex. This is easily and safely treatable, so that's where we're going to put some of our focus on today. So what is happening down there? When we start to go through the menopausal transition, that loss of estrogen, in particular that special estradiol produced by the ovaries, causes anatomical and functional changes. And these changes can cause physical symptoms. And this is what is known in the medical world, I said it before, as Genitourinary Syndrome of Menopause. So we'll call it GSM for short. So what's actually going on? For one, the tissues of the vagina and the vulva are starting to lose collagen and elastin. These are the same things, same processes that are going on in our face. So in our late 20s to early 30s, we're already making less collagen and elastin. Collagen and elastin are known as structural proteins, so they provide strength and support to our skin, and they give it its elasticity. And that loss of estrogen around midlife accelerates this process of decreased production of these proteins and increases the breakdown. And this is why you might feel like all of a sudden you're looking older. I personally felt like it happened literally overnight. Something just happened to my skin. And in case you're new to the party, estrogen affects every organ system of our body. So that would include the biggest organ system we've got, and that's our skin. Now, interestingly, we have an abundance of estrogen receptors around the genitals, our face, and our lower limbs. And so these areas are especially vulnerable to this reduced amount of circulating estrogen that happens around this midlife transition period. Now, other things are happening here too. So the epithelial layer, so that's the tissue that lines the vagina and that skin tissue on the vulva, these tissues become quite thin. And then the number of blood vessels in those areas also decrease, so we get less blood flow. So essentially the tissues become thin, they lose their fullness, they become less elastic, and then that means that they can sag and tear easily. The vagina can also shorten and become more narrow, which could then obviously contribute to discomfort when you've got thin, easily tearable tissues in a shortened, more narrow vagina. Our perception to touch can become either more sensitive or decreased feeling. We can experience a loss of clitoral stimulation. The tissues can sag enough that the front wall of the vagina, or the back wall, or both, can sag down into the vagina, which is called a vaginal wall prolapse. So some of the symptoms of GSM would be vaginal dryness. As I said, we lose our ability to self-lubricate. Painful intercourse, which is called dyspareunia. Vaginal bleeding and discharge. Remember, any bleeding after menopause needs to be discussed with your doctor. It's not normal to bleed after menopause. Vulval burning, dryness, irritation, or itching. And sometimes you can get little fissures around the vulva, so little cracks in the skin, which are really painful. You can get urinary symptoms, so you might start getting recurrent urinary tract infections. You might feel some urgency when your bladder gets even somewhat full. You might feel like you're busting, you need to get to the loo. You could start getting some incontinence, so urge incontinence, when you feel like you need to get to the toilet, you need to get there, or you might lose your water. Or stress incontinence, so if you cough, laugh, jump, sneeze, a little bit might come out. And then you also might get some pain when you wee, which is a symptom also of infection, so it really does need to be checked out when you get pain when you wee. Now, all of these things can then cause difficulty with arousal and orgasm. And as I said before, you can get bleeding or spotting, and that can occur after or during intercourse, and that needs to be discussed with your doctor. And then, no surprise, all of this can lead to a loss of libido. And if this is you, you are most certainly not alone. Some studies have found that half of us, 50% of women between the ages of 50 and 60, report symptoms. And that increases to 72% in women over the age of 70. Now, interestingly, only 4% of these women associated their symptoms with a loss of estrogen at menopause. So I guess maybe it's just another thing we think that we have to accept and grin and bear it. Estimates are that we're only treating about 7% of women. This is another conversation that we really need to be having. The most bothersome symptoms reported were vaginal dryness and the dyspareunia, so the painful intercourse. And some women have multiple symptoms and other women don't have any. It's like this whole kind of menopause thing, isn't it? Now, there are things that can increase your risk of getting GSM. So if you've had your ovaries out before menopause, if you've had a premature ovarian failure, so before the age of 40, if you're a smoker, if you abuse alcohol, if you have a decreased sexual frequency or abstinence, if you haven't had a vaginal birth with your babies, if you have other causes of low estrogen, if you've had cancer treatments like radiation to your pelvis or chemotherapy or endocrine therapy. So what can we do? One of the things that we can do is stop using soap around the vulval area. So you can get shower no soap washes at the grocery store or at the chemist. Avoid products around that area that are fragranced. If you wear panty liners, ensure that they're hypoallergenic. Don't douche. Remember, we have lots of normal bugs in the vagina, and douching can actually remove the normal ones, and then the bad ones can overgrow and cause more problems. You can use an emollient cream, one that's made for sensitive skin if you've got itchiness. Emollients contain oily substances, so they're often used to soften and smooth the skin, and they're one of the things that you find in a moisturizer. Lanolin would be an example. Now, sometimes lanolin can affect tissues and cause problems, but it's more of a, trial and error type thing. Now, these are for the vulval area, but for the vaginal area, there are such a thing as vaginal moisturizers, and these can actually provide longer term relief. So, moisturizers rehydrate the dry tissues by changing the fluid content in that epithelial layer. So we talked about that outer layer, and it mimics vaginal secretion, and the effects can last up to 3 days. And then a personal lubricant is going to be really important. Lubricants can relieve discomfort from friction and pain with penetrative sex. Lubricants are used when you have intercourse. They can be water-based or silicone-based. So if you want something that's versatile, it's easy to clean, it's not messy or sticky or staining, then you're going to want a water-based lubricant. If you're looking for something that's going to last a bit longer and it can withstand water exposure, then a silicone-based lubricant might be better. If you have sensitive skin or you're prone to allergies, then definitely go for a water-based lubricant with hypoallergenic ingredients. If you use silicone sex toys, a water-based lubricant is also going to be better there so that you avoid degrading the material. You can also use things like olive or sweet almond oil. And then recently there's been a bit of publicity around using coconut oil in a paste form. And I've had a look at the literature. It's pretty interesting. It appears safe, no adverse events, and you can buy it at the grocery store. I would opt for an organic version if you can. And then if you're on anticholinergics, antihistamines, decongestants, or antidepressants, they could be contributing to vaginal dryness. So it's worth having a look at those and seeing if there are alternatives to see if that helps. Now, that leads us to vaginal estrogen. So we're missing the estrogen, right? That's the problem. And so if we replace it, then that can help. They're extremely effective. So vaginal estrogens come in either a cream or a tablet. A tablet is in a little applicator. It just gets inserted into the vagina. With both of the treatments, you usually start by inserting it every night for 2 weeks. And then after that, you use it between 1 and 3 times a week. I tell my patients whatever you can use at the most minimal amount to continue to get the effects that we want. So they're very good at reversing those atrophic changes, so that thinning and loss of volume in the pelvic tissues. They improve blood flow and the thickness of the epithelium in the vagina, the bladder, the urethra. So that's where you wee from. There is very minimal systemic absorption. So it goes to where you want it. It goes to those pelvic tissues and not necessarily to the rest of your body. You do get a small initial peak, and then after that, you almost get no further absorption. So it's very safe. A paper was just released recently that talked about even women who've had breast cancer before can safely use this in most cases. So for women who've had breast cancer, there are 2 cases where it should be discussed with the oncologist first, and that's for women who've had hormone receptor positive breast cancer and they're currently taking an aromatase inhibitor. An example would be anastrozole or letrozole. Or for women who've had hormone receptor positive breast cancer premenopausally and they're currently taking a GnRH agonist. An example would be Zoladex with an aromatase inhibitor. Those 2 cases should be discussed with the oncologist before starting vaginal estrogen. But for everyone else who's had breast cancer, they can safely take a vaginal estrogen. A woman might start noticing a difference in her symptoms within a couple of weeks, but the maximum benefit is going to be at around the 3-month mark. So I suggest that my patients give it that full 3 months before they decide where they're at with it. Now, I have said multiple times before that if you're on an estrogen, then you absolutely need a progesterone to protect the lining of your uterus, but this is an exception. You do not need a progesterone in this case. You can use just the estrogen in the vagina. I might just I'll say a quick word about vaginal lasers. At the moment, from what I understand, there's currently insufficient evidence for lasting benefits, and it would be very much operator dependent on the results that you get, and it's quite expensive. So they're not at the moment recommended generally. Now, you can take hormone replacement therapy for vaginal symptoms. So the hormone replacement that you take for all of your other symptoms, so in your patch or your tablet or your gels, those kinds of things, your hormone replacement can help, or menopause hormone treatment can help with these symptoms. But if they don't, then you might also want to try adding in a vaginal estrogen as well. So you could go the MHT, HRT route and use some vaginal moisturizers and lubricants. And if you're not happy with that and it's not giving you all of the relief that you would like, then you certainly could try also vaginal estrogen. Now, I mentioned that there were some other causes for decreased libido. One was that our decreased hormone state can cause this decrease in libido. So yes, hormone replacement therapy or MHT, menopause hormone treatment, can help independent of your vasomotor symptoms, so your hot flushes. So it can also help with libido. But if you've tried MHT, HRT, and you've excluded or treated all those other causes that we've listed previously, and your libido still hasn't improved, then there's a place for testosterone therapy. So testosterone, that's a male hormone, right? Wrong. Women have testosterone too, just like the boys. And the boys have estrogen, just like the girls. Did you know your male partner, if you've got a male partner, probably has more estrogen in his body right now if you're postmenopausal and you're not on hormone treatment? About 50% of testosterone, or the prohormones, precursors, the things that are turned into testosterone, are made in our adrenal glands. We've talked about this before. Those are those little glands sitting on the top of our kidneys. And then the other 50% is made in our ovaries. Some of it's made in our developing follicles, so our developing eggs. And some of the precursors, so again, those things that are going to be turned into testosterone, are produced in the actual ovarian tissue. So this is why it's thought that menopause doesn't actually drastically decrease our testosterone levels, because even though the follicles are no longer producing the testosterone, the tissues are still producing the precursors that give us testosterone. So our levels of testosterone are not impacted by menopause. In fact, our levels of testosterone peak in our early 20s, and then they start an age-related decline. So our levels decrease by about 25% from the ages of 20 to 40. And again, no acceleration around the time of menopause. They just continue to do their age-related decline. Over the age of 70, our levels, for some reason, return to our 20-year-old levels. They start increasing from about 65 years old. I couldn't find any scientific evidence to say that our libido increases with it, though. Now, there are blood tests for testosterone. It's a bit tricky in a woman to get accurate levels and only recommended in a couple of cases. So if there's concerns that you have too much testosterone, or if you're going to start testosterone therapy, then these are the times when you have a blood test to see what your testosterone levels are doing. Current studies don't support the use of testosterone for any reason other than treating libido for women. This includes for muscle mass and for protecting our bone health. So there is a TGA approved testosterone cream in Australia for women. You apply it to your leg or your bum every day. It takes about 6 weeks to start seeing some effects, and maybe even up to 12 weeks. And the therapeutic effect is determined by our symptoms, so not blood levels. Blood levels are checked just to make sure that we're not getting too much, but we're actually guided by what's happening with the patient. If there's no benefit by 6 months, then it needs to be stopped. Common side effects are mild acne and body and facial hair growth. This could mean that the dose is a bit too high, so you might need to back off a little bit. Less common side effects are weight gain and fluid retention, and serious side effects are clitoral enlargement and voice deepening, which both can be permanent but are very rare. And if it's being monitored and managed appropriately, then very unlikely those things are going to happen. But for that reason of the voice deepening, one of the people that probably shouldn't be prescribed testosterone are professional singers due to that rare possibility of an irreversible effect on the voice. It should also not be used in women who are being treated for hormone-related acne, excess body hair, or balding, so androgenic alopecia. Testosterone should also not be used by women who've been diagnosed with a hormone-dependent cancer like breast cancer. So that certainly needs to be discussed with the oncologist. It's on a private script, so it's not covered under the PBS in Australia. And so it's a 1% testosterone cream. Although there's a 2% strength available, it's for use in men only, and it could result in testosterone levels approaching the male range, and so it should not be used in women. Nor should compounded testosterone formulations, because, as we've talked about in previous episodes, it's very unreliable in the strength of testosterone that you're getting. It's not regulated, and so hard to know exactly how much testosterone is in the product that you're actually getting. It could be too much, could be too little. Hard to know. So there you go. We've really gone right through the GSM. All of those things can really impact libido, and it's a very common cause of a decrease in libido for women. So making sure that you've got those symptoms managed can be very helpful. Making sure that the relationship is healthy and working towards that if that's a problem. And then if you've tried hormone replacement or menopause hormone treatment and you haven't quite got the benefit that you would like in terms of libido, and you have fixed all of those other things, then testosterone certainly is an option to explore with your doctor. I hope all of this has been helpful for you. A lot has happened since the last podcast. It seems that it's really been picked up and gaining popularity in lots of places, which is really, really exciting. Thank you all so much for your support. Again, I'll ask that you take a minute to rate and review the podcast. Again, that just makes it more visible for those who might be looking for this information. I have reflected just recently on how difficult it has to be for you guys who don't have medical knowledge to sort through all the information out there, because
you hear these claims from people who seem pretty reputable,
who have these pretty strong opinions about how things should be done. And I personally want to stand on the side of science and evidence-based medicine. It's important that people are aware that you could find a study to pretty much back up any claim you want to make. And so you have to look at the quality of the studies to determine whether or not it's something that you're going to listen to. And unfortunately, there are some people out there who are shouting from the rooftops and not using evidence-based medicine. So I promise you that I will do my very best to always make sure that I am bringing you the best information that I can and clarifying when it's my opinion versus what I have been able to find to back up that opinion. Yeah, so I hope that that's all been helpful. Again, thank you for your feedback. Leave me comments or suggestions if there's anything else that you would like to hear more about. I'm thinking in the future I want to do an Ask Me Anything episode. So if you want to start sending in those questions, that would be awesome. If I get inundated with questions, I might just do that sooner rather than later. On my website, optothrive.com, there is a suggestion box that you could submit questions to if you'd like. So there you go. I hope you all have a great day. I hope you have a great couple of weeks. Keep listening. And until then, I hope you opt to thrive.
The Opt to Thrive podcast is designed for information purposes only and is not engaged in the giving of medical advice. The information provided on the podcast should not be used for diagnosing or treating a health problem or disease. In no way should the information provided by Opt to Thrive be considered medical advice, and at all times the advice of a medical professional should supersede recommendations from Opt to Thrive. If you have or suspect you may have a health problem, you should consult your healthcare provider. The views expressed in this podcast are purely that of Dr. Sims and do not in any way reflect those of the institutions she contracts medical services to.
Thank you for listening to Opt to Thrive. If you've enjoyed listening, please rate and share the podcast. You can visit our website at optothrive.com and leave a comment for any subjects you would like to hear more about.